Good morning, everybody. Welcome to today's webinar. My name is Dina Johnson, and I'm from JFK Partners at the University of Colorado School of Medicine. And today's topic is about transitioning from pediatric to adult healthcare for people with intellectual and/or developmental disabilities. And we are pleased to have our speaker, Dr. Jessie Solomon-Saunders. Dr. Saunders is an assistant professor of pediatrics at the University of Colorado in Denver. She completed the 6-year neurodevelopmental disabilities or NDD residency training at Boston Children's Hospital, which included 2 years of pediatric residency, followed by 4 years of training in adult and child neurology and adult and child NDD. She has participated she has particular interest in improving the transition from pediatric to adult care for patients with complex neurodevelopmental disabilities. In her current position, she initiated an adult developmental disabilities clinic in collaboration with adult neurologists at the University of Colorado, where she provides a consultative neurodevelopmental care model in the adult hospital system at UC Health. Dr. Sanders also serves as the attending physician in the Developmental Pediatrics Transition Clinic at Children's Hospital Colorado. She is dedicated to developing more opportunities for adult neurodevelopmental care in Colorado and across the country through clinical model innovation, collaboration with colleagues across disciplines, and mentorship of trainees. So we are recording today's event, and we'll record it and we'll archive it on the JFK Partners website along with the handouts. And following the webinar, you will receive an evaluation link where you may request a certificate of attendance. So with that, I hand it over to Dr. Solomon-Saunders. Thank you for being with us.
Thank you so much for having me. I'm excited to get to talk to this group, and I am going to share my screen now. So y'all can speak up if you can't see the slide. Just to confirm, can someone unmute and tell me, did the slide advance? You can see.
We can see it. I can see it.
Perfect. Yeah. Thank you. I once did a presentation where my slides didn't advance and I didn't know till the end, and only I was looking at them. So thank you so much. So I am Jessie Solomon-Saunders. Thank you for the lovely introduction. I'm excited to talk with you today about transitioning from pediatric to adult healthcare, specifically focused on people with intellectual and/or developmental disabilities, IDD. And teamwork is going to be the name of the game. Also, if you have questions, feel free to put them in the chat, and Christine will be monitoring the chat and unmuting and telling me any questions we want to pause and answer, so we can have a discussion throughout. Here's the goals of what I have to talk about today, and also happy to answer your questions and your goals as well. But I want to help define transition as we know it, and also define transfer. Also want to discuss healthcare disparities for patients with intellectual and developmental disabilities as they age. We will review research about healthcare for adults with intellectual disabilities, and we'll talk about what's out there and what's missing, and some new research that's happening in the pipeline. We'll outline the process of an ideal healthcare transition, but wait a minute, there is no ideal, and that's what we'll talk about. Each transition should be tailored to each family and patient's unique situation and unique timeline and preferences. But we'll go over what's been considered best practices, so we're all on the same page. And then I think the highlight will be always hearing from the perspective of patient and family who's undergone transition from pediatric to adult healthcare. And so that family will join us later in the talk, and we'll also answer questions. So what is healthcare transition? Healthcare transition is a dynamic process of moving from a pediatric model of care to an adult healthcare system or model of care. Through transition, the goal is to prepare youth to receive care within the adult healthcare system. And that includes caregivers and youth preparing for receiving care in that adult healthcare system. Transition should be patient-centered, developmentally appropriate, comprehensive, and uninterrupted. And these are all big goals that take a lot of smaller steps to achieve. But overall, transitions are part of a normal, healthy development, and they occur lots of times throughout the lifespan. And so transition in healthcare is a dynamic process where we want to meet the individual needs of children and young adults as they move from pediatric to adult health models of care and health systems. So I love this picture. This is Jonathan. I'm using a different name than his regular name just to protect privacy, but they've given permission to use the picture. And so as you'll see in a lot of my pictures, I love tandem biking. I think it's great teamwork and it gives support for people to be able to do activities that they might not be able to do on their own or propel them to do more independent activities. So Jonathan had never ridden a bike. It was something that his family had wanted him to do for years, if not decades. And they thought, oh, he'll never be able to do it. So they came to a tandem bike day and all we heard from his father was, he'll never be able to do it. He has this medical problem, that medical problem. He can't talk, all of these things, all these reasons why he's just not going to be successful. But here we are, go ahead, give it a try against all odds. So lots of people supporting the bike. We got him up on the bike for the first time in his whole life. And his father, fists in the air, says, he doesn't need me. And I will just remember that moment forever. And so the goal is not to not need someone, but to realize that there are lots of supports available for helping transition to adulthood and independence. And that can look lots of different ways. So it might be on someone's independent two-wheel bike, or it might be with the support of a tandem rider or something in between. And we can find what works so that that family can feel that sense of independence. I told you we'd talk about the research in transition. And so there are many publications about transition, but very little evidence about the effectiveness of interventions. So this graphic is from a Cochrane study in 2016 that reviewed dozens of studies, but only included 4 randomized controlled trials. And we know lots of people are learning more and more about the research process with COVID. It's becoming more popular to talk about. Randomized controlled trials are the gold standard, and there's only 4 out of all of these studies. A newer study from 2019 found 7 randomized controlled trials. So they all show mixed results for differing outcome measures. And the conclusion ultimately in both of these reviews is that there's no definitive evidence that any specific intervention in transition is effective, which is really hard. So there's many possibilities that we have to move forward transition ideas based on a long period of increased awareness that this is needed, but there's not yet solid research to tell us this is the exact way to do it. So this is to demonstrate and show you that a lot of what we're going to talk about today is really based on consensus, based on doctors and professionals, schools, families, social workers, lots of consensus together of what makes a good transition, but unfortunately not hard research based. So one of the most famous research consortiums for transition and policy influencers for transition is called Got Transition. And so their website is gottransition.org. This graphic was from Dr. Mia Asato's grand rounds over the last few years. And so she has allowed me to borrow this graphic that explains the Got Transition 6 core elements of what transition entails. So what gottransition.org, their consensus says, is that the transition process should start with the family and healthcare team all having a shared understanding of a transition policy around age 12 to 14. So what will transition expectations be in the future? The next step is starting to track progress. Then assessing skills of transition readiness. And so there are some validated questionnaires out there that test the transition readiness of families and of patients themselves ready to transition to adult healthcare. We'll go over some of those tools a little bit later. I'll show you some examples. And I'll also, more importantly, give you the link so you can see all the tools that are out there. But assessing skills annually, it should happen 14 to 18 or beyond. Also in the same time, developing a healthcare transition plan, and that includes a medical summary. What does this person's care entail? Starting to develop and write out that plan so we know what's going to happen. Then step 5, this is the hard one where people often call the cliff, is transfer to adult-centered care and integrating that patient and that family into adult-centered care. So this doesn't necessarily specify that it has to be an adult practice, but it should be an adult model of care that will last them through the lifetime, that they won't then have to transition again. And then age 18 to 26 is confirming that transfer is complete and getting feedback from all members of the team. So this is the framework that has been longstanding. It's been in practice for over 10 years, supported by gottransition.org, which has a lot of federal funding, but realizing is based a lot on consensus. So they have incorporated teachers and parents and youth and doctors and nurses and social workers and therapists, but it is not research-based, it's consensus. So this is another consensus statement that's just about 5 years old. And so the Child Neurology Foundation is a nonprofit organization that is an advocacy organization for children with neurologic diseases of all kinds. And so it advocates for families and children. And they were hearing more and more that a big problem children have is that difficulty transitioning to adult care. So even though they're the Child Neurology Foundation, they took this up over the last 8 years to be one of their priorities, is helping with the transition process. So one of the first things they did 7 years ago was gather consensus from lots of child neurologists, adult neurologists, people in industry, families, as we said, all of the same groups that the consensus was sought for GOT transition, but focused on people with childhood onset neurologic conditions, which is more in line with our population of intellectual and developmental disabilities. And so they saw the 6 core elements of transition, and they created 8 common principles of transition. And so these are principles that should all be taken into account throughout someone's youth and child neurology care. It's not necessarily as stepwise as gottransition.org, because they realize that transition can happen at different times for different medical needs and for different developmental stages. And so one person who's 14 might be at a different developmental level than another person who's 14. And someone's family of someone who's 14 might be at a different level, ready to talk about transition or plan for things, than another family. And so these are the principles of transition and are not meant to really prescribe ages, but are meant to document and explain what should be involved in transition. So it's really similar expectation of transition. There should be a shared expectation of what will happen when someone moves to adult healthcare, and if that's an expectation. There should be yearly self-management assessments. So we should be constantly looking at and reevaluating where someone is in thinking about transition, both families and caregivers and youth themselves. There should be an annual discussion of the youth's medical condition and their age-appropriate concerns. And we'll go over each of these more in detail. There should be evaluation of legal competency. And again, this is by the healthcare team, not necessarily just the doctor, but this is all about working as a team. There should be an annual review of the transition plan of care, and then define responsibilities of the child neurology team, or this can be replicated to the pediatric team in general. Define the responsibilities they have and identify adult counterparts and adult providers, and then finally make that transfer. The goals of transition overall can be forced into buckets of medical transition, school and employment, which is a huge conversation that we could spend weeks of webinars on its own, and same with legal transition issues. So because we only have a short time today, I'm going to focus on the medical transition. One of the reasons the medical transition is so hard is because there are major differences between the pediatric model of care and the adult model of care. So a lot of times people think of a pediatric model of care as more paternalistic. We help guide families through decisions, whereas the adult model of care thinks of, we generally think of that model as thinking of patients as more independent. They make their own decisions, you give options, and it's not as collaborative. I don't agree with that, but this is the consensus. So I work in both models of care, and I think that we both work in both ways, but this is general consensus as why people think it's harder to transition. People think that pediatric model of care is more holistic versus symptom-based, and this is something I've experienced. For example, child neurologists are all board eligible or boarded in pediatrics, whereas adult neurologists are not even board eligible in internal medicine. So when I started seeing patients in my new clinic in neurology, I had a new clinic in Boston before I came here. In that clinic, I learned that when I see someone with decline or changes in their behavior in pediatric neurology, I mash on their belly, I look in their ears, you try and find, you can test their urine, you do a more holistic way of evaluating that person because we're trained in being pediatricians and doctors that specifically treat the brain and evaluate the brain. Whereas when I moved that model of care to an adult neurology practice, my colleagues that were adult neurologists were quite uncomfortable. They said, we haven't done an abdominal exam since our intern year, and we don't look in people's ears. We don't even have an otoscope in the clinic. Those are just a couple of examples, but it made me learn that in order to be successful in this adult model of care, I really needed to build a team and partner with primary care doctors, and more importantly, teach that partnership to other brain-based specialists who are used to treating just dementia or just seizures or just a stroke. And if there might be something else, then they partner with primary care doctors. So I learned to advocate for and model that partnership so that we could still provide holistic care, but in a specialized setting that treated the patient with neurodevelopmental disabilities as they needed to be treated, but allowed them access to the adult neurology setting. So it's a dance and a balance and learning our networks. I think most important, one of the challenges that we have with transition, which we'll talk about, I'll show you some research on, is the level of comfort that adult providers have with developmental and behavioral issues. So a lot of families find that adult providers just don't see this as much and don't see those issues as within their wheelhouse, when really it's what families need to address. Any questions or anything?
There's nothing in the chat yet.
Okay, great. So we're starting to see the beginnings of adult care models that can address the comprehensive needs in select settings all throughout the country. So there are certain care organization concepts emerging that can help distribute needs of these vulnerable populations. For example, ACOs, accountable care organizations, are helping centralize and also spread the risk that healthcare organizations take on and realize that it does take a team and incentivizing that. So again, that's a whole other topic and concept to talk about in a different time, but I do have hope that some of these changing models of care that we're seeing in Colorado and throughout the country is just the beginning, but very exciting, of allowing us to have more capability, not just by changing people's minds and comfort, but by incentivizing people differently and helping create these team models that can care for people as they need it. So what are the goals of healthcare transition? I think of the goals, and a lot of the consensus statements is what this is from, is maximizing lifelong functioning and potential. So throughout the transition process, we want to promote self-advocacy and we want to teach self-management skills in collaboration with caregivers and patients and youth. We want to prevent this bridge to nowhere. So really a main goal also is good communication and uninterrupted services. So a successful transition leads to continuity of care, fewer gaps in clinical follow-up, improved access to care, and decreased financial barriers to care also. So when you have that seamless transition where you go from one doctor to another, not having that gap is huge. A lot of times, once someone doesn't have a doctor, it's a lot harder to get started with a medical team than if you have one medical team that transitions to another. And I think we'll show that when we go through the elements and the principles of transition, of how important it is to have the teams happen in the same amount of time of that transfer, that there is no gap in that. It doesn't mean everything has to transfer at once, but it means that we don't want to leave anything hanging. We want to know who's in charge. Is it the pediatric person or is it the adult person? And that's what a good transition means. It doesn't mean that everything jumps from pediatric to adult at once. We also know that successful transition leads to improved adherence. So one example of that is improved disease control, for example, seizure control. We have research that shows that when someone transitions well, they have better seizure control, fewer emergencies. There's also improved quality of life. And this is my best buddy from the Best Buddies program. We've been buddies for over 15 years, Christy, who had a great transition and has been working at the same job at a grocery store for quite a long time. And so her quality of life is great, but she has support of a good medical team that helps her be able to keep her job and all of the other things that make her great quality of life. What are the consequences of a poor transition? So we know as clinicians that preparing youth for adulthood has consequences if it's not done properly. There's risk for medical complications. There are problems with treatments and medical adherence. There's discontinuity of care and higher acute care utilization and costs. So if we're going to convince anyone that it's important to do this transition well, this is one of our main pieces of evidence that if we successfully transition someone from a pediatric to adult model of care, it will overall cost less. It's hard to think in the long term for these companies, insurance companies and government insurers, but that is really an important reason that we have to stress. For us, more importantly, is all of the issues that affect youth and families.
Do you have a question?
Yeah.
Alyssa wants to know, how often does a provider initiate a care team transition to adult care versus a family coordinating team transfer?
That is such a great question. And I really think that it's both. And I think it happens it happens most successfully when both parties are ready for transition. So I think that in the younger ages, in that 12 to 14, it is important for the provider to bring that up, because I know if some of you are parents or have kids or know kids that are 12 to 14, you're not really thinking about adulthood then. You're getting into middle school and thinking about maybe soccer or feeding or whatever it is that's happening in that time in that youth's life. And so bringing up transition then can help the family realize that there's a doctor who's thinking about this, or a healthcare team member, not just doctor, that's thinking about this, and that they're gonna keep talking about it. So I think that early, it's important for the providers and the team to bring it up. Same thing with the school team, so that the family knows this is something we're not gonna just let happen. We are gonna purposefully make this a good, streamlined, successful process. So these consequences, which are scary, might be why many caregivers and family members hesitate leaving the security of pediatric care. It's hard because so much of the youth population in general does not need much healthcare in their 20-somethings years. And so overall culture doesn't really support transition efforts in the general population. So transition.org works a lot with the general population to support those transitions, not specifically for people with neurodevelopmental disabilities or childhood onset neurologic disorders. But things like the Child Neurology Foundation and us supporting the minority of children, the ones who it's really important to have that transition because they do need continuity of healthcare, is sometimes an uphill battle. So it's important for everyone, but it's not as prioritized for the general population of youth in their 20-somethings to transition. So we do face a bit of an uphill battle. So speaking of the need for transition services, we were talking about some of the consequences. Here are some more examples of consequences of poor transition. So we unfortunately know, this is from National Care Indicators, which is collaboration of state developmental service agencies, Women with intellectual and developmental disability or developmental disabilities are less likely to have cervical and breast cancer screenings. Those are life-saving screenings that you can intervene on quickly and easily if something is caught. And it is not acceptable for women with intellectual and or developmental disabilities to not have access to that, just like the general population does. They're also less likely to have ever visited a gynecologist. These are just a couple of highlight examples I wanted to show you. There is so much literature out there, but I didn't want to focus on all the bad today. Adults with intellectual and or developmental disabilities are also less likely to visit the dentist regularly. And we know that poor dental hygiene can lead to other health problems and complications. They're less likely to get eye and hearing tests, which is appalling because if someone's behavior is changing and they can't hear or see as well, that is a huge problem. They're also less likely to receive vaccines. We know that lower income households experience even greater disparities. And one of the most horrific disparities is knowing this fact that patients with sickle cell disease, this is just one example, but appalling, have an increased risk of not just all of these poor outcomes of morbidity, but increased risk of mortality during the transition period. That means dying. So transition is a literal risk of death in that population of patients that is just so important to address.
We have a couple questions.
Yeah.
Christine wants to know, does gottransition.org address the other areas of school, employment, and legal transitions?
So gottransition.org addresses them a bit, but I've always had difficulty with gottransition.org that it really focuses on if you follow these 6 core elements, you will have a successful transition. And so I think that their research is great and I respect and appreciate all of the work and years of research that they've done. But I think that more is needed in terms of how they respond and guide the literature for our population of people with intellectual and developmental disabilities, where following those 6 core elements doesn't always get you to a successful transition. So I think that I have all the website linked at the end, and I also send out the PDF as well of all of the slides. So you'll have the links, but the Child Neurology Foundation has a lot more literature on guardianship planning, things like that. And there are also some Colorado specific guidance as well. So I would say that in terms of for our population, school and specific to people with intellectual and developmental disabilities, that the Child Neurology Foundation resources are a little more applicable, but that the Got Transition ones certainly can be adapted. And they talk about school planning, vocational planning, but it's not as specific to patients with developmental disabilities. It's more general.
Thank you for that. Jennifer also wants to know, is there a difference with who the client is living with, host home provider versus family?
That's a great question. I don't see a difference because we have to work as a team with who that patient is getting, or youth or adult is getting their support from. So whether that's someone they're related to or someone that is part of a service agency, I think it's so important to all work together. I don't think it matters at all, but that's part of what we need to consider is what are someone, if they're living with family, what are their goals for the future when their family situation may change, as all of our family situations change as we age, and we have to help people plan for their goals and their family's goals. Maybe a host home is a goal, or there are other family goals for living situations in the future. That's a huge conversation we have.
Thank you.
Yeah, thank you guys. So just a couple more slides dwelling on the barriers to transition, but this is just showing, we talked about all those disparities, and this is just showing how one disparity begets another disparity. So someone with intellectual and developmental disabilities already has higher rates of adverse health conditions. We know that. But then that leads to disparities in attention to their care needs just because they have an intellectual or developmental disability. Then that leads to disparities in obtaining preventive and health promotion practices, which leads to disparities in equitable access to healthcare, which then leads to poorer health outcomes. So we have a lot of barriers to break down, but we are working on it. And the system is improving, honest to goodness, every day, especially here in Colorado. So this is from a nationwide study looking at the National Survey of Children with Special Healthcare Needs. And there are several different elements that they highlighted each year. So in this year, this is from 2018, this data is from 2010, they highlighted transition. And so the question was, did you receive the services that you needed to transition to adult healthcare, work, and independence? And so the blue is if someone has an emotional, behavior, or developmental issue, and the orange is if they didn't have emotional, behavior, developmental issue. So you can see that in the general population, the outcome is only achieved. So they did say that they received the services they needed less than half the time, but it's just about half that in patients with developmental disabilities. And then the outcome is not achieved, they answered 71% if you have a developmental disability, or half of the time if you do not have a behavioral or developmental disability. This is a study that some colleagues in Boston did about resident comfort with outpatients that specifically asks, how comfortable are you treating these conditions? This is asking residents, which means they're doctors in training. And this is to remember that 90% of children with chronic conditions, including intellectual and developmental disabilities, survive to become adults. So maybe 50 years ago, when our mentors were in training, Down syndrome was only a childhood illness because the life expectancy was less in the 70s than it is now, thanks to advancements in heart surgery and how we support people in the community. But now it's not acceptable. We see people living into adulthood, well into adulthood. And so the light gray bars is pediatrics residents' responses of what percent felt comfortable. And the dark gray is adult internal medicine resident responses. So you can see the difference with pediatrics residents said they're comfortable compared to so few adult residents comfortable with autism, cerebral palsy, the same disparities in Down syndrome. Whereas if you look at a medical problem that is through the lifespan, like asthma or diabetes, they're pretty similar. So this just goes to show that internal medicine residents see these disorders as within their wheelhouse, but they don't see these pediatric onset neurodevelopmental disorders as within their wheelhouse, even though they're just as common to be seen in adult practices in the adult population as they are in the pediatric population, given how many people are coming into adulthood. This is a survey I did in the last 2 years that is submitted for publication now, but not yet published. So we surveyed 412 residents affiliated with the Harvard Medical School residency programs. And of them, 96% said they had treated a patient with intellectual or developmental disabilities, and 24% said that they received formal education about intellectual or developmental disabilities during their training. So only a quarter said they've received any education. And that is not even going into what is the quality or content of that education. We surveyed a lot of things in the survey. I'm just going to highlight a couple. So one of the questions we asked is, how comfortable are you treating patients with intellectual and or developmental disabilities? And just over half say they felt at all comfortable treating a patient with intellectual or developmental disabilities. So that means half were uncomfortable treating a patient with developmental disabilities. So very comfortable was only 5%. Somewhat comfortable was 29%, a little comfortable, 24%, a little uncomfortable, 26%, somewhat uncomfortable, 15%, and very uncomfortable, 2%. So we have a lot of work to do to help people feel comfortable. And we need more research to figure out what we can do to get residents and doctors in training and doctors in practice comfortable treating this population as comfortable as they are with asthma or diabetes or anything else. We also learned from this study some of the barriers, and I'm just highlighting a few of them, but we know that transition, all of us know that a good transition takes time. You have to locate resources. You have to learn new information that might be outside of what you learned in your medical school or residency. And it takes advocacy on the part of the providers and the healthcare team working to get someone into a good transition setting, and advocacy on behalf of the youth and the family and caregivers. It also takes tenacity. We all know that one phone call doesn't just get you in and get an appointment. So it takes a lot of tenacity and persistence.
We do have a comment and some questions.
Thank you.
Sure. So going back to the discussion of who a client was living with, Jennifer mentioned that she was surprised thinking that clients that are connected with an agency would be more likely to get gynecological care and vaccinations.
That's a great point. I think that that's a big part of what we talk about in transition is getting connected with an agency like a community center board or somewhere that a case manager or case worker, or I might not be saying the right words for each agency, but someone can help oversee the care and make sure that everything that needs to happen is happening. But unfortunately, overall, no matter where you live, people with developmental disabilities have less vaccination rates, have lower vaccination rates and preventive care rates. So that's just national data. But I think you're right. In personal experience, having a good advocate, that's where this advocacy, having a community center board or a caseworker or an agency help make sure that they're checking off the boxes of what you need for your good health is really important.
We have a lot of stuff happening in the chat all of a sudden. Tracy has a question. Does your clinic, oops, I just lost my chat.
I just unshared so I could see
you
it.
You unshared, everything moved. I'm sorry, just 1 second.
Okay.
Okay. Does your clinic or GOT transition start the discussion of shared decision-making? Oh my goodness.
Yes.
Okay, and at what point should this discussion begin?
That's a great question. So let me table that one because I have a whole slide about talking about that. But absolutely, we start that discussion, but we don't make decisions for them. We just start discussion about options.
Okay, we have a question from Rosa, and it says, are there specializing docs and healthcare? I'm not sure.
So, Rosa, that is the dream and that is the goal. I know Dr. Martin, we're lucky to have on this call, and I'm sure there are other doctors on this call. I can't see all of the people, but we have a lot of people lately who are more and more interested, and Dr. Martin's been doing this a lot longer than I have. And so that's the goal, is to get and train more doctors to specialize in treating and working with adults with developmental disabilities. We do have specialists in pediatrics, so neurodevelopmental disabilities or developmental pediatrics, child neurology, all work on this subject, but there's not as many yet on the adult side. So that's a big goal that we're working on throughout all our careers.
A comment from Christy talking about resident comfort level, how that is not even the reimbursement, and which of those take Medicaid. So that's very sad.
Absolutely. It's a huge problem.
Okay. Rini says, I work with both youth and adults with IDD and co-occurring mental health concerns. There are also low, if any, comfort level or willingness from medical providers to support individuals with comorbidities.
Absolutely. I couldn't agree more. And that is my life's work. So the data that I shared with you, I didn't have time today to share all data and projects that we have going on, but that data is actually the pre-survey of an intervention that we designed to help improve the comfort that doctors in training have with people with developmental disabilities. And so we saw some promising results, but it's not yet published, that their comfort increased after we provided experiences interacting with people with disabilities. So we brought artists who are developmental disabilities that are employed at an art studio to have lunch with resident doctors in the hospital and bring art projects and teach them an art project. So sort of flipping the classroom, as they say in medical school. And that the surveys show preliminarily increased comfort. So that's just one intervention that we're working on. And if any of you want to email me ideas of other interventions to help doctors feel more comfortable, that is my passion and what I'm here to do with my career. So, and Dr. Martin said that he and many others have tried to develop formal training, like a fellowship or certificate program for family doctors or internists on intellectual and developmental disabilities without success. But I feel grateful to come on the heels of all of that effort. Because like we said, tenacity, advocacy, lots of applications for fellowships and things take lots of years to demonstrate. So we are going to continue to work together to build the data and build the case for why that is so needed. And then I see the question about asking if there's a resource on vaccinations for people with intellectual disabilities. A lot of families are scared to get their kids vaccinated. Absolutely. So I am happy to share, I have a blurb that I always say. I say that people with developmental disabilities overall, if it's just the developmental disability, not either health reason to not get a vaccine, but developmental disability, I say that think about when your kid misses school, why we have extended school year. It's because being out for a long period of time, those developmental gains can step backwards so much easier than they can in patients and children who don't have developmental disabilities and adults. So I say we do anything we can to prevent a severe illness that could cause an even bigger setback than it could in the general population. And I always say that we have lots of really strong research that shows that vaccines do not cause or impact or make more severe any developmental disabilities, including autism. So happy to share more of what I have. I don't have a specific resource. I just make my own paragraph and send that to families. Thank you all so much. This is great. And can you all see the slide again?
Looks
Yes.
great.
Okay, thank you. So I'm going to go through now, because I think this will answer some of the questions. What I'm going to do is go through the Child Neurology Foundation 8 core principles of transition, and I'm mixing in some of the GOT transition principles. And I'm also going to share how I view it, because it's not always what's perfectly done on paper with consensus statements when you're working with people like we work with, people with intellectual and developmental disabilities with a variety of needs. So start early talking about transition. I do think that's important. So anytime I see a baby with Down syndrome in clinic or another diagnosis early in life, the first question I almost always get asked at an initial visit is, will they be able to get married? Will they be able to have kids? So it's naive for us to think that families aren't thinking about the future from early on, but it feels uncomfortable as providers to talk about it in these young adolescent years because we feel like we're kicking someone out. So we have to realize that it's doing a service to talk about this early. It is not being rude. It is not showing you're going to kick them out. It's showing you care as much as they do about their kids' future. So start a discussion about what their goals are. Set expectations, because you as a family member or a provider, you know this youth pretty well, or you have to get to know who knows the youth well. So this is for families to guide them. Ask your doctor when you'll have to transition to adult care. Some hospitals or clinics have set rules. Some say your disease process is so specific that I will treat you forever in partnership with an adult primary care doctor or another adult provider to help add the adult piece. And some say something in between, that, well, we'll see you until you find this adult doctor in your young 20s. So figuring out that pattern young so that we know what to expect. And asking the pediatric providers, will they help you with this process and how? So this is guidance that the GOT transition and the 8 core principles gives to families, which answers that question of who brings it up. And the recommendation is both sides should bring it up. And begin to set the goals and expectations of independence. So like with Jonathan, the guy who his father thought would never ride a bike, that was setting his expectation a little bit low. We want to set expectations of what someone can do independently and what someone can do with support and what supports they need to be able to achieve those goals. So we want to set aspirations high, but realistic. So will they go to college, a college program that supports people with developmental disabilities? Or will they have vocational support or jobs? And what are the goals? And start developing a plan to meet those expectations. And the biggest question young in this age group is, who do we need on our team? And starting to amass that team. So the second core principle is doing self-care assessments. So really starting to understand as a provider, someone from the healthcare team, and as a family, where you are in the transition process. So the Child Neurology Foundation and gottransition.org, they have different self-care assessments that can be taken by families, parents, or caregivers, and by youth themselves or youth with the help of a caregiver. And that helps you realize annually, where is this person? And sometimes someone with a developmental disability, it might not be a goal for that person to know their own medicines, for example, but how can we adapt that goal? So realizing that the self-care assessment doesn't have to be taken so literally, especially in our population, but could it be someone has a wheelchair that they have a medication list laminated and tied to their wheelchair or something like that, making a plan for what will happen when this person is an adult. So lots of different developmental levels. Also in this self-care idea is thinking about, depending on the developmental levels of the child or youth, begin to have them check in for their own appointment, whether they can speak or not. Use a communication device, say that they're here, greet the person at the front desk, have them learn their diagnosis, whether that's saying it or showing a card that they know where the card is. These are all ideas of how to improve their self-care and independence. It's really important around this time also, which is the whole transition time period, to make an emergency plan and keep updating it. So make a medical alert or bracelet or necklace or tag for someone who is less verbal or might be overwhelmed in a situation. So someone can be able to say, here, this is my diagnosis, or here are my communication needs. They can advocate for themselves. You could give them a wallet card. These are all just ideas. Again, not evidence-based, but consensus ideas. A wallet card could say what their diagnosis is, their seizure type, what medications they take, their allergies, emergency contact information, medical contact information, all of that handy for the person. We want to this is number 3 principle in the Child Neurology Foundation 8 core principles, annually discuss the medical condition and age-appropriate concerns. So we should think that this is a no-brainer, but it has to be said that you need to annually discuss with the youth their medical condition, because they might somehow start to be ready to developmentally understand it. Was there a question? Discuss with them their current medications and potential side effects, and their signs and symptoms, any concerns. Discuss their genetic. What is the reason for their developmental disability? Do we know the etiology? And if we don't know, check for it. Talk about the options for genetic testing. And then if you have those results, talk about reproductive implications. Go over issues of puberty and sexuality and preparing for that, or at least advocating that family and the care team prepare for that, even if you don't have time in that one visit. Talk about driving, alcohol, substance abuse, and other risks. I always say, just because someone has a certain diagnosis doesn't mean they might not be interested in sex, drugs, rock and roll. We have to assume everyone has access to these things and provide anticipatory guidance to everyone. And really discuss emotional, psychological concerns and wellness. So annually, all of these things should be discussed with a transition age youth with intellectual or developmental disability or childhood onset neurologic condition.
We do have a comment and then one question.
Yeah.
Rochelle says that regardless of their developmental age, include them anyway in medical discussions. Folks might be surprised, which I thought was a great comment.
I completely agree. That's awesome.
And then Kathy wanted to know, when Children's Hospital Colorado, when does the hospital want an adult to transition?
That's a great question. And it's specific to each clinic, not specific to the whole hospital. So each department makes their own goals of transition. Generally, this is not specific to Children's Hospital of Colorado, but I would say generally from my experience and my family members and friends' experiences, it's hard to become a new patient if you're 18. And so that's what I tell families is we want to identify someone so that, let's say your doctor moves or retires or changes their practice. It's hard to become a new patient if you're an adult in a child-focused practice, whether that's a children's hospital or not. So that's an idea to keep in mind. But a lot of people, I saw my pediatrician until I went to college and through college. So I think that's pretty common to see a child-focused doctor through the early 20s, but it's not standardized, for better or worse.
And Rosa has a question, I believe, regarding the content on this current slide. Docs and parents have this discussion together or just with parents/guardians?
I think that having this discussion together is really important. And we realize that not all doctors have time to talk about all of these things in one visit. And Dr. Martin, you're welcome to join in too. And how it works in primary care, where visits are shorter, might need to have separate visits. And there are codes for transition planning and transition discussion that can help make it so that insurance covers those separate visits to talk about these important things annually.
Thank you.
And Dr. Lucchese, I see your comment. Thank you so much for noting that your program, which I believe is Aurora Mental Health, provides counseling services to adults with intellectual disabilities with co-occurring mental health. So important. I think a lot of my patients benefit from your care. So thank you. And you are outreaching to clients and offering case management support to get them a COVID vaccine. That's amazing. Thank you so much. And yes, the link to the presentation will be sent out and the slides. This is great. And we should always keep people, the patient themselves, youth, adult, anything, no matter their developmental disability or diagnosis, as part of the conversation and keep their goals in mind. That is so pivotal. So the fourth common principle in the child neurology 8 principles for a successful transition for people with childhood onset neurologic conditions is discussing legal competency. So there are lots of options. And really, as medical providers, we don't see that the patients are, that the doctor is necessarily the one who dictates what's going on or dictates what direction to go, but helps connect the family with resources to make that decision and give input and fill out forms of their opinions and knowledge of the patient's condition and developmental functioning as indicated. So there are several options for helping people make decisions legally. So there's medical and or financial power of attorney. There's a proxy decision maker, which hopefully everyone on this call has identified a healthcare proxy for if something unexpected happens, that you know someone would help make your decisions. There's supported decision making. And then Guardianship Alliance of Colorado, here's the link, offers classes that discuss each option in detail and help families decide what's best. So I send patients there and they find it very useful. Full guardianship means having a court-appointed guardian who makes decisions for that patient. And that's not always the right decision. So just because someone has an intellectual or developmental disability does not automatically mean they need full guardianship. They could possibly benefit from a different option. And this is not an exhaustive list, but this is just a list to know about, and that doctors should know and the healthcare team should know that it can be a difficult decision and we can be there to support the family, but that we can't make the decision for them. It's really something that the youth and family together needs to make, or caregivers. And also I tell families that it can be changed. So no, it's not easy to go to court and change it, but it doesn't mean it's not possible. So just because one thing is right for someone at age 18 doesn't mean that's the same decision for age 24 or 34 or 54. And so we can keep revisiting that with the social work team and other members of the team to see what's right for this family. So principle number 5 is that there should be an annual review of the transition plan of care. And this should be developed in collaboration, no matter what, with the youth, the healthcare team, school, and vocational professionals. And this should address healthcare, finance, and legal concerns, primary care, other specialty care, education to employment, housing, and community services. So Dr. Martin said from his experience as a primary care doctor for hundreds of people with developmental disabilities that it can be helpful if the patient transitions while they're still on their parents' healthcare insurance, since Medicaid can be a barrier to entry into some primary care practices. So that's good advice, absolutely. A lot of patients are on Medicaid as children also, and so we work to find practices. There's a new practice, Salud Family Health in Aurora, that has a med-peds trained doctor, someone trained in internal medicine and pediatrics, who is seeing adults with developmental disabilities, Medicaid accepting. So there are options out there, but that is a really good piece of advice. It keeps more options open if you transition, well, if that's an option for that family. And then this is great, Luke from the ARC. Thank you for joining, that there are videos on the ARC of Arapahoe and Douglas County website about supported decision-making and guardianship. There's really wonderful options. And then in Wyoming, the site, you can use the Colorado website and resources. I think that's absolutely fine. I don't think that the idea of making the decision is that different. I think what's different is the nitty gritty, how you go to court, where you go, what you need to do. But coming to the decision, you can use the Colorado resources to help make the decision. So number 6, that's really important, is Knowing who is doing what during the transition process so that nothing gets dropped. I can't stress this enough, that really defining responsibilities of each team member throughout the transition process is, I think, the most important of all of the core elements at every age. The seventh core element is identifying adult providers. So how can we help our patients access adult providers? We want to give adult providers tools to feel confident accepting the transition age patient. So all of the things we talked about earlier in this the principles of transition, I think, and based on talking to other adult providers, help make it more palatable to accept that patient with developmental disabilities into your practice. If that patient is coming with a well thought out plan of care, information about the condition, prior records like imaging, genetic testing, brain, like what their brain looks like, and any other information about their disease, if they're coming with all that information, makes it a lot easier to say, yes, come on into my practice. I know it's not just that easy, but those are some things that I've found with talking to other people, other adult providers, that it makes them feel more comfortable accepting this patient when they know there's been a lot of preparation for this process and there's a plan of care in motion. Finally, the final step is transferring to an adult provider or an adult model of care. And so there's no specific age as we talked about, but it's an important step. So I wanted to tell you a little bit about the transition clinic that I supervise at the Children's Hospital of Colorado Developmental Pediatrics Department. And this can be, a bit of a gold standard of an ideal what we do. So it occurs monthly. We see patients 14 to 26, and it's a 2-hour visit, an hour with a doctor, an MD, and another hour with social work to address all of the issues. And of course, you can't address it all in this clinic, but really what we end up doing is laying out for the family these elements of what's needed so they can start thinking about it and bring things to their primary care provider and others. So it's just really the opportunity to talk about all these things. I always think nothing what we do there is groundbreaking, and then families just love it and are so grateful. So I really just think it's taking the time to go through what the steps are for transitioning and brainstorming families' goals with them. So here's some things we do in this transition clinic. One thing is we help the family, we start blank. And in the visit, we help the family draft a portable medical summary. So we have them write out, what are the healthcare needs? What is their current problem list? Do they have a trach, a G-tube? Do they have seizures? Other things to know about. What medications are they on? And then contact information, emergency contact information. All of this, if you have this all together, first of all, it helps with safety with a person with developmental disabilities, knowing where everything is if someone else is helping take care of them or manage their care, but also really helps when you're going to that adult provider, having this all together. So we help a family draft this, but it's not completed during the visit. It's just showing an idea. We also provide an after visit summary for the primary care doctor as well, of their diagnoses, of the plan, and most important, the medical transition action plan, where we identify, and this is a much longer grid, but I just didn't want to waste space on the slide. So there's lots of goals, issues, concerns, what action needs to be done, and the most important thing is who is responsible. So let's say the goal is checking the making sure the blood is healthy. And the issue's concern is last time they had thrombocytopenia, low platelets. So the action is follow up on the annual blood test and who is responsible. That's what's so important. So we'll say for this time, for example, the pediatrician is responsible. But if the family tells us, oh, we have an appointment with a new primary care doctor, we'll say, okay, let's put that person's name as who's responsible for following this up. So the family is never left to wonder, wait, who's following up on that blood test? What about that MRI? What about that IEP idea? We want to document who's doing what. That's a big part of what we help families do during the transition clinic. But again, you can do it, and if there are other providers on here, you can make this kind of grid for your patients and help them fill it out. It doesn't take us at the transition clinic to do it. It's just something we do and it's helpful. We also provide this roadmap for the primary care doctor, which condenses all those elements that I just spent an hour talking about from gottransition.org and Child Neurology Foundation, condenses these elements and we wrote them into what's relevant for our patients who all have intellectual and/or developmental disabilities into checklists for a doctor to follow. And then the family can follow along and bring this to their primary care appointments and prompt their doctor, all right, we're 16 now, so we should be drafting this summary. So help making a roadmap for the PCP, but that can be available for anyone, and any patient can have this. You can download it from Child Neurology Foundation or from gottransition.org and bring it around and self-advocate, or we have more and more pediatricians now using this, which is fabulous. That's the goal, is that every patient doesn't need to be a transition clinic patient, but we can help when it's really complex. So Transition Clinic is a resource for patients with developmental disabilities to plan for the future, both medical and non-medical aspects of life. I told you I'd talk about bikes too much, but each transition will look different for everyone based on your own personal needs and comfort. So moving from a seat to a trailer bike to your own bike, some people might move to a tandem bike where they have support, and some people might move to riding separately from someone. And, you know, all of them are great successes. We just want to know people's goals and how to support them. So the digital format, we right now share it as a Word document, actually, that gets emailed to the family, and it's shared in a letter format, the digital passport, where families can, it's this one, where families can copy and paste it onto their own computer and edit it. It's 2021, but you wouldn't believe the amount of hours that, and I've only been here 6 months, that we have with the IT teams to make this editable from both providers and patients. So right now it is not editable in the medical record from the patient viewpoint, but they can copy and paste it into a document on their own computer. That's the best option we have right now, but we're working on making it editable and able to fill out, but that is, it is a challenge with all of the safeguards that medical records have in place. So we talked about the transition clinic, where we see youth and help them transition to adult healthcare. This is my new clinic at UC Health, University of Colorado, where I do consultations for adults with developmental disabilities, not primary care, but neurology, and it's housed within the behavioral neurology clinic, where they see mostly patients with dementia, Parkinson's, other adult behavioral neurology disorders. And now we are so lucky to add to that adults with developmental disabilities. So we see patients for consultative care, and it's not psychiatry and it's not primary care, but sometimes it's what caused this person's developmental disability, helping pursue genetic testing in adults, or helping understand why that patient has declined or their behavior has changed. And so there's lots of different reasons that we can consult on patients that are adults with developmental disabilities. And so there's the phone number and the address, and we are open. It's just 1/2 day a week on Wednesday afternoons, but we'd love to see anyone who needs it. So from this clinic, I've seen a lot of patients over the last several months and heard even more stories. We were inspired to make a survey nationwide, wondering how youth and adults are faring in the pandemic. And this is showing us that behavioral health challenges that pre-existed or even didn't pre-exist have worsened. So in this survey, so far, we have 245 responses. We were hoping for more. We asked people how you'd rate your overall physical health. Most people said good. Very few people said poor or fair, and 1/4 of respondents said excellent. Whereas when we asked the same question just down the line, how would you rate your overall mental health right now? Very few people said excellent, and many more people said fair or poor. So that is really concerning, because we know that mental health changes and deterioration can affect physical health. We know it's all connected. So we wanted to do this survey to show the importance of services. So this is showing some of the importance of adult services, showing the importance of transition. And when all that's taken away, we get this impact of fair, poor mental health. So we asked how your services have changed because of the COVID pandemic. So about paid work and employment, unfortunately, 63% of respondents said that I never did this. 21% used to do this, but now cannot. That is terrible. So 21% of people used to work, but now cannot because of COVID. 7% work, but less, and only 9% continue to work. Same thing with day program, very similar. 41% used to do this, but now cannot. And so we really think that that's impacting the health. And so this survey study will really help us advocate for what's important, because by demonstrating what has changed because of the pandemic and correlating that with how people's behavior challenges have changed, we can hopefully advocate for better transition services in the future. Of course, the pandemic wasn't caused by a transition failure, but what the impact was is very similar to what would happen if people lose their services because of poor transitions. So we think that this will be important to show. I'm pleased to be able to share with you some of the very preliminary data, but we'd love to have you and colleagues and families, individuals that you know, youth and adults, share your story. So if you could please, you can snapshot, if you bring up your phone and you can take a picture. If you open the camera app on your phone and just point it to the QR code, that will pop up with a link, or you can type in this link, https://redcap.link/COVID impact. And we would really appreciate you sharing your story so that, or your youth or young adults or people that you know. We've gotten a lot of great qualitative data from this survey also. This is and it's all anonymous when you fill this out. Your name and everything is not included, separated from the data. People said, for 1 year, I haven't been able to do speech therapy. People now cannot understand me. COVID has affected my life, the life of my family. This is not news to you, but this is just to share. We want to hear your story so this horrible and challenging piece in time is documented for us. So thank you in advance for taking a picture of that QR code and sharing it with us. So any questions, and then we are going to move towards the patient and family perspective, but we'll pause for questions first. And here are the resources, the links: Child Neurology Foundation, gottransition.org, and iddtoolkit.org.
There's a lot.
For the survey, participants can be any age, 0 to 1 million. There's no age difference or limit.
Going up in the questions a little bit, Alyssa wanted to know if integrated primary care practices feel more comfortable accepting IDD patients.
That's a good question. I don't know the answer to that off the top of my head. I think we'll hear from our patient and family perspective. Sometimes what's helpful is seeing a primary care doctor who already knows your family. So if a parent has a good relationship, sometimes they'll feel comfortable. But I haven't studied. So that's an interesting next topic of research, studying the comfort of an integrative practice versus other primary care practices. That's a great question. Let's study it together. Message me.
Luke just posted the new question about sharing the page for the survey.
Absolutely. Thank you.
Anyone, if you have a question I've missed, go ahead and feel free to repost it for me. I know there's a lot of discussion up there a little bit. I don't see anything else popping up at the moment, Dr. Sanders.
Okay, great. Well, we are so lucky to have a family come join us who has taught me really everything I know about lifespan care for people with developmental disabilities. I've known this family and their kids since I was in high school and have experienced their experience growing up. And I'm just really honored that they're able to join us. So John, if you can unmute, thank you so much for coming.
Can you hear me?
Yes, we can hear you. Thank you.
Amy.
Yes, we can see you.
Okay.
You look fabulous. So thank you so much for joining us. We would love to hear your perspective on what it was like to find adult healthcare providers for your adult children with developmental disabilities.
I understand what you were saying at the end there about, we'll start with primary care. Our primary care physician knows our family, knows the girls. So as the girls aged out, it was a natural transition over from the pediatrician to the primary care. No big problems there. In the specialty cares, it was a little different. Our pediatric orthopedic surgeon, who did extensive work with both girls, referred us to a physiatrist simply because he thought he would be better suited with the girl's individual needs, better than an adult orthopedic. And as it turns out, that has been the case. For our one daughter, Molly, since she's aged out, has had two pretty huge surgeries. And in both instances, we were back into the children's world, the pediatric world of orthopedics, simply because there aren't very many adult surgeons who do scoliosis surgery. But the pediatric world is well versed in that area. So we find ourselves going back and forth, not because we want to, but because that's how it works out best for the girls. Some of the doctors, like the ophthalmologist, has kept Molly on board. She's 22, kept her on board simply because she doesn't feel the adult side of the world is quite right for Molly. However, she felt Mira, our oldest girl, when she turned 21, boy, she said, here's a recommendation, and it worked out great. In fact, we just saw that doctor yesterday, and Mira likes her, she likes Mira, so everything's working out well. The dentist has decided to allow the girls to stay with him. He sees no issue with looking inside of the adult mouth as opposed to a peds mouth. So they're both doing well. No issues there at all. Earlier in your discussion, you mentioned legal issues, guardianships, conservatorships, power of attorneys. We discussed that at length with a bunch of different people and ended up going with the guardianship simply because it gave us a more permanent, all-encompassing feel for the control we wanted the girls to have, somebody to have. It's funny when you make an appointment, you ask questions or whatever, and they'll go, who are you? And we used to say, oh, Dad. And they go, oh, okay, with no question. I mean, I could be anybody, but if I said Dad, that was fine. If I say guardian, lights and bells go off. They want to see paperwork and things like that. So if you're going to go the guardianship route, scan it, carry it in your phone, so you have that court order with you at all times. We found that very helpful at times. Anything else?
Thank you so much, John. Anyone in the audience? I have a couple more questions I can ask too, but one, I know we don't have a ton of time left. So does anyone that's here have questions for John, who has so expertly navigated this challenging process? And John, did Mira or Molly want to say hello?
Just 1 second.
Okay, if they would
like.
like.
They're out in the front room.
Okay, no problem.
Bring them back?
If you'd like, especially if Mira wants to tell us about her adult experience, her job, things like that, that would be great.
Just 1 second.
Okay. Great. So that's a great question, Kathy. So since Children's does some transitioning by clinics, is it possible to have some docs at Children's Colorado and some at UC Health or University of Colorado? Does it make things more complicated? I think that the best way to transition is to do it stepwise. I don't think that you should transition everything all at once. So my dad used to tell this joke of like a parrot who talked about pull my right leg, pull my left leg. And then someone asked, what happens if you pull down both? And he says, I fall down, silly. So I think that that's what happens if you transition everything at once. There's a chance of it all falling down. Hi, Molly.
Say hi.
It is so nice to see you. We're so glad you're doing well after your surgeries.
How you doing? You know who that is? Oh, yes.
Hi.
She's waving to you. You just can't see her.
I see it. I can tell. Awesome. So transitioning one thing at a time, I think is actually the best way to do it. So it doesn't all come down.
One of the biggest issues we had was not so much, this is our cat, Jessie. Molly named her. I'll let you guess why. Okay. Not so much in the medical world, but in the world of state services. I was shocked. The pediatric services, she turned 21, to the adult services, is like trying to jump across the Grand Canyon. I thought it would be a very smooth transition, but apparently the adult side of the house and the ped side of the house don't talk to each other. And it took us over a year to keep Molly's services to get them back up and going, which surprised me a lot. Now, I don't know if that's just our state or if that's the way it is everywhere, but it's something for parents to watch out for. And we even started our process a year early, knowing she was going to turn 21. And it's still, like I say, a monumental task to get services outside of the doctor's office reestablished. So, hey, Mira.
And I think that's why at the beginning of the talk, we talked about starting it earlier and identifying team members who will make sure that transition happens. Because even starting a year in advance, you don't think there's that much to do, but you keep learning all that you don't know is going to be difficult. So, hi, Mira. It's really nice to see you. So, Mira, you have transitioned to adulthood. Before COVID, what did you do during the day when you were graduated school? What did you do after that?
To work.
That is so cool. And
Mira worked in a restaurant 3 days a week as a table busser who kept all the condiment trays filled. She also went to a developmental therapy workshop 3 days a week. Of course, all that ended with the COVID.
Of course.
We're not back yet. We're taking steps to get there.
And I learned from John and his family how important it is to talk about the goals with the medical team, because with some of Mira's medical needs, there are certain jobs that would be feasible and there's certain jobs that just wouldn't be recommended, certain job placements. And so that's a conversation that the whole medical team plus the education team needs to all get on the same board for, and planning early to find a job that's a good fit with Mira's passions and skills, and also some of the medical things.
Right. If your state education department has a vocational rehab section, we did here, and they worked very closely with Mira. She, oh golly, worked a half a dozen different placements for 1 or 2 or 3 days to see how she fit in. Wow. That experience was invaluable.
That's great. Really great. Can you tell us about supported decision-making? How do you deal with making decisions together now that they're adults, but you also have guardianship?
We discuss it all with them so they understand what's going on. The decision is still ours. We let them know so they're part of it, but their input is minimal. We take it into consideration. So it's not just blindly do as I say.
Absolutely. And I know you had to make some difficult medical decisions recently. And Molly, it seems like you're really happy with the outcomes. Is that right? You're feeling really good? So some surgeries that you decided to do, but that John and the family worked together for what would help Molly feel the best. So even though Molly can't verbally agree to it, she knows she feels better, and that's
we know she feels better. If you remember Molly, the last time you saw her at camp or something, when she sat in her wheelchair, her hips were cocked and twisted. Her foot was resting on the footrest instead of the platform because her scoliosis was just so horrible. After the surgery, she sits straight and square in the wheelchair, feet flat on the platforms. She's now 2 inches taller than she was pre-surgery.
Wow. Wow.
You can tell she's much more comfortable just being here.
I'm so glad to hear. That's great. And she's lucky to have a great decision-making team together working in her best interest. That's fabulous. What has been the hardest part of healthcare transition? I know you had talked about finding an obstetrician, gynecologist, something like that.
We've had the girls on board with an OB for years, so that was no transition at all.
Okay.
She took the girls on as young girls, and she's still there with the same doctor.
That's great.
Like I said, the ENT issue, as an example,
Mm-hmm.
we transitioned from a peds ENT to a adult ENT.
Mm-hmm.
Molly had some issues with her salivary glands. I brought it up with the new ENT, and he just said, no, you have to go see a peds guy. I don't know anything about salivary glands. Well, okay. So we've been working with a peds one again, and Molly's scheduled for surgery with him in July. And like I say, it was the same thing with the scoliosis surgery. They pushed us right back to the peds side of the house simply because that's where scoliosis is normally dealt with.
Mm-hmm.
The neurology side of the house has been a little cumbersome. The issues both girls have neurologically, most adult neurologists don't see. I'm not sure why. I don't know what happens to the young kids who grow up because their neurological conditions don't change. So there should be adults out there who had these issues as children and still have them, but finding doctors who are familiar with it is kind of tough. Now that could be because of where we live. When we lived in Cleveland, resources almost were unlimited. Not so much where we are now. In fact, a lot of the care of people we know because of our support groups and everything, there's a lot of out-of-state travel for the same type of care we used to just do in Cleveland by driving downtown. You don't do that here. As an example, when we first moved here, both girls were under the care of a pediatric endocrinologist. And when we were getting set up with the children's care team at the hospital, I mentioned that. They said, oh, well, we have an endocrinologist that comes in from Portland twice a month. Wow. Traveling doctors. I didn't know they were still around, but there they are.
Wow. Well, you guys have impressively amassed a team, and you've really had to deal with the flexibility of finally getting into an adult system and then realizing that the specific need wasn't possible, even though you had that adult doctor team or medical team. So then you had to keep that team, but go back for specific issues to the pediatric system.
Yep. And it's been, I'm sorry.
No problem.
Put a silence button on these things. I should learn how to use it. Okay. The adult side of the house are very involved in our consultations with the ped side of the house.
That's huge.
No rivalry or anything like that. In fact, like I say, the adult folks are the ones who have referred us back to the ped side. And for the most part, in fact, for all of them, the peds guys have never said, you're 21. We don't treat people over 21. We've not run into that issue with anyone.
And I think that's important to realize that it's because it's a very specific need and consultation that an adult specialist is asking for help specifically on a salivary gland or specifically on a scoliosis question, but that in general, the managing doctor has moved to be on the adult side, which is, that's kudos to navigating that complex cross stream.
Yeah, you know, we do this stuff and we don't think twice about it, but we've been dealing with this issue. We have three older kids who are in their 40s. We went through the same thing with them. They're all special needs adopted. And so we've been doing it this transition for 30 years. And just through experience, you learn where the hurdles are and the landmines and how to avoid them.
Absolutely. There was a question in the chat if you've had experience transitioning mental health supports, if that was an experience your family has had.
Not because of the system, but because of COVID. It's been particularly hard on Mira, our oldest girl. Before COVID, she worked 3 days a week. She went to the DD therapy place twice a week. So she was out of the house every single day and absolutely thrived on it. And then all of a sudden, bam, in a matter of a week, she was at home. And she's been at home since. So we've tried to, every day, we try to get in the car and just go for a drive someplace to get out of the house. Cabin fever is a horrible thing. So we get them out and about. Just last weekend, we went out to dinner for the first time in over a year. So everybody thought that was pretty exciting. We're discussing getting Mira back into her job and see where that goes. I know she would love it. That paycheck was something that was pretty nice.
That is so cool. I hope so. I hope we can all come dine there. That would be great. We have about 1 more minute until this is over. Mira, do you want to share your news, the really exciting?
Yes. It's amazing. I won
Idaho.
Miss Idaho going to Nashville.
Congratulations. That is so cool. So Mira won Miss Amazing Idaho and is going to travel to the national competition, share her talents and passions, and just awesome. All your hard work, other people seeing. So congratulations. Really cool. A lot of people, Mira, in the chat, people are typing in and lots of people are saying, wow, congratulations. So lots of excitement, even though you can't hear if we were all in the same room together. Very cool. We're all really excited. Thank you guys so much for sharing your perspective and your experience. You've really seen so many different ends of the medical field, the good, the bad, and everything in between. So we really appreciate your perspective. I think we'll have to end now, but we will keep conversations going. And thank you again. Really appreciate it.
All right. Good seeing you again.
Great to see you guys.
Bye-bye.
Bye.